So TKR and spinal stenosis, and the first thing which may seem elementary to the number of spinal surgeons, but it's very easy for us to see the ergonomic body posture. And we have to look at the poor posture, the good postures and all. And the main thing is that in the advent of an aging society, we're living longer. The abnormal posture with the body balance disorders is a serious issue, because this is leading to decline in activities of daily living and health-related quality of life. I think we are all, the spinal surgeons are of course conversant with that of the cone of economy, which refers to the upright body posture, maintained by the skeletal muscle strength of the body, and involves everything, right from the foot and the pelvic circles and the bigger ones which goes above. And all of this is the cone in which a person moves and retains balance and a good posture. So the balance efforts and the center of equilibrium dimensions are found to be significantly greater in degenerative lumbar spinal pathologies. And patients with degenerative lumbar spinal pathologies presented with lower levels of activity. So even if you have a knee problem with that added to the degenerative lumbar spinal pathology, which is presenting with lower levels of activity, you have a double whammy. So this is the posture which we all know. And the investigations to detect spinal problems is well known to all of us, but not so well known to the arthroplasty surgeons, that we need to take x-rays of the lumbosacral spine, the AP and side bending and lateral and extension, and of course now the sitting and standing position x-rays to judge the pelvic obliquity, which will determine the hip positioning of how much anteversion to give and how much not. The MRI, of course, we're not great experts at that, and sometimes a CT scan and a 3D reconstruction. In most clinical symptoms are restricted to the knee alone, that's the one they come to us with, but in 10 to 15% are simultaneous knee and spine symptoms, which Ram has already talked about so beautifully. Sometimes the spine symptoms are intermittent and not so important as we judge them and after talking with the patient. And in other, spine symptoms are dominant and knee not so, and without significant deformities, but pain. So in these cases, when both are equivalent, is the real problem, with significant radiological findings on both sides. And here I must say that we always refer to the spinal surgeon for his opinion first. He opines first whether the spine should be operated first by all his methods of x-rays, MRIs, blocks, all sorts of procedures which they use. And then they recommend to us that, okay, the spine needs to be done first, and we leave that decision to him. That saves us a lot of trouble later on. If we look at the clinical tests that we have to do for the knee and all that, we above looking for the polyarthritis and the pain deformity, etc. On the back pain, since we are not that much a spine people, we do the back pain, we look at the radiation, which is very important for us. Intermittent claudication, neurogenic or vascular. We look at the back muscle spasm, bony tenderness, sacroiliac or paraspinal tenderness, and bladder bowel signs. And deficits of neurological or vascular, the SLR persistently there, and the lassitude test, etc., which we learned about. But the main thing is that we determine at that particular point whether the spine is a simple one or a complicated one, and what is the issues arising from the spine, which we can detect and which we need desperately the spinal surgeon to look at it and tell us as to how to proceed on that. The knee spine syndrome, there's knee hip syndrome, knee hip spine syndrome and all that. And this measures the simultaneous changes in knee flexion and sacral inclination, as you can see in these figures. So as the knee flexes, the sacral inclination will 5 degrees less when the knee flexion group, and when the knee flexes, you get increased patellofemoral pressure, you get patellofemoral plane, and of course, with that amount there, then when you do the knee, ultimately, the correction of the flexion deformity is a problem when the patient stands. And you have patients with these spinal sacral inclinations who have gross knee contractures. And even if you correct it on the table, the moment he starts walking, it tends to recur and it gets very difficult to correct that flexion contraction. So if you look at the standing and the sitting of the sacrospinal, you look at the sacral slope that changes between standing and sitting. And that is a great issue in pelvic inclinations. And that is a great issue in when you're doing your hip placements. The knee also, you have to look carefully at what is there in the hip always. And judging by the previous things that we always do in the decline above, etc. The whole thing is that if there is a hip problem and a knee problem, we tend to do the hip first. Is knee arthritis linked to spinal stenosis? You bet it is. Patients with pre-existing lumbar spinal stenosis have lower functional outcomes of the TKR. And if you look at the severe lumbosacral stenosis has reduction in the AP diameter of the thecal sac and increased morphological grading. And this correlated with a significant reduction in preoperative ROM that was not improved after total release. So persistent postoperative reductions in the range of motion after recovery from the training contribute to reduced patient satisfaction and recovery. And that is one of the reasons why almost, let's say 20%, some say less than that, 15% or 10%, but there is patient dissatisfaction. So these are familiar to the spinal surgeons. I won't go into that, but there is grade 0, 1, 2, and 3, and the severe ones as individual nerves are compressed into severe crowding and depression. The severity and location of the lumbar spine stenosis affects outcome of the wound. And that is a fact of life which we have some have learned it the hard way, and now we tend always to look at the spine, always, before doing any investment. So we have to tell patients that they can expect relief of arthritic symptoms following TKR, but they may continue to experience limitations in postoperative function relative to their expectations. And of course, which Ram quoted this paper, the multi-center study, which showed that the lumbar spinal stenosis is at a problem after arthroplasty. Concurrent degenerative knee and lumbar spine disorders and the type and severity of the knee deformity, and that was Goodman's paper, which Ram made my job easier by quoting it beautifully. And as he said, the severe valgus deformity and windswept deformity, where the knee is obviously at a problem, there's obvious deformities, and that will have to be tackled first. But if there is absence of deformity of the knee or mild deformity, then the spine surgery first. And we had this survey in which the spinal surgeons and the joint replacement surgeons, and they both had identical deformities. So preoperative TKA could be a benefit for the properly corrected sagittal spinopelvic alignment by spinal fusion. Therefore, preoperative TKA should be considered as a surgical option for patients with severe sagittal spinopelvic parameters in concurrent and degenerative ASD. But this is only for short level fusions less than 3 seconds. The algorithm in that, what we follow is a radicular symptoms of spinal pathology should be treated first. In cases of predominant back pain, which could be either due to loss of lumbar lordosis or precipitated by deformity by alignment to osteoarthritis, knee replacement is considered first. But whatever we do, a close relationship with the spinal surgeons, and we talk over each and every case with them before he or we touch the patient. And as Ram said, of course, the patient. Of course, always the patient and the family. So this was a 57-year-old Jenny Valgas. This is the spine, had definite spinal symptoms. This was treated with a short segment fusion by the spinal surgeon. And this was a result, which usually is such a satisfying operation that you get. This is not an uncommon situation at all. In the case 2 of mild spinal symptoms, no radiculopathy, no deficits, X-ray has mild lumbar spondylosis, no question at all, go for the knee. And this we did a CR 150 as Ram so correctly pointed out, that what you do is different, but you make your decision which part you're tackling first. And then the spine operated. This was a long segment fixation with a knee pain of 10 to 70 degrees ROM. And this was, we did this, this thing, though she had a good, I couldn't get her knee thing, she was walking well. But what happens is that her range of motion improved only to 90 degrees. And we had counseled her from before that. So that was what she accepted quite easily and was happy about it because she could walk. Now, most of these patients, even these ladies, they want to go out. And one of their things is traveling. And most of them want to travel to quite some distances. In fact, all of our patients that we've seen with this problem, they travel. And the first thing is that, can I travel? Can I go by this train? Can I go by bus? So they are quite walkers that way. So the take-home message basically in total knee replacement, always consider the spine. And we cannot do anything without considering the spine or the spinal surgeons. Of course, we have to examine clinically and listen to the symptoms. As again Ram had pointed out, listen. Everything, all the things they say, they can come out equally, that what are the things that are aggravating their pain and what are they thinking about. Do investigations, and if we as arthroplasty surgeons find anything significant in the spine, we will refer it. We will refer it anyway, but we'll do it with gusto. We counsel the patient that with spinal problems, the results may be compromised as regards motion range and pain relief. And again, this counseling, as Ram mentioned in a triple way, that this counseling and this sort of information has to be given to the patient who has spinal problems with knee problems. Sometimes the TKR first may relieve the back pain as we showed, but cross knee deformity has to be tackled first. Thank you.